pretty basic concept, but something I embarrassingly didn't actually know. And I've seen a couple of pitfalls from it recently. So, or a few people mistaken it. So can someone tell me what the structure is right here?
Anyone in the chat? I have a guess.
Do you think it's a lymph node or not a lymph node? Let's start there. I can't hear.
Could this be the celiac axis?
Yeah, that's my thought too, celiac ganglion.
Yeah, so this is the celiac ganglion. You can see it's between the adrenal gland and usually the aorta or diaphragm here. It's also, it's bilateral, but here's the one on the right. You can usually see it better on the left. So I'm just pointing this out because we've seen some cases of this being called a lymph node and measured, and it's not a lymph node. And it's also important, like in pancreatic cancer, if you see, the tumor involving towards the celiac ganglion, then that would probably be someone who would benefit from a celiac axis or a celiac nerve block, even though they would be otherwise, even though they're inoperable, but that would be something that they would benefit from. Okay, that's all.
Teresa, that's a great case. And actually I have a companion case. We recently had one like that. And it was called like a potential lymph node or paraganglioma. So I'm also going to call that one up as well. And in CT, sometimes it's a little bit easier to see. It's usually like oblong, but I just found my case. So I'll show that one too.
On which one did you say it's easier to see?
On CT, just a little bit easier to see.
Oh, like CT. Yeah.
Great. Awesome case. Anyone else?
I'm pulling up a case, but you go first. And then when I'm ready, I'll share mine.
Okay. I'm going to try this. It's on my laptop. So if I'm going to try to do this gingerly. Okay. So this is just my companion case to the one that Teresa just showed. You can see that the liver is fatty and that there are multiple cysts within the liver. But the lesion that we were looking at was this enhancing ovoid lesion here. And yeah, it's just a nice companion. So we've got our adrenal gland right there. We've got a renal cyst behind it. And then we've got this enhancing celiac ganglion here. So don't mistake it for a lymph node or for an exophytic adrenal mass. Okay. My next case is this one. You guys can see my screen, right?
Yes.
Yeah.
Okay. Okay, so this patient presented with melena. And I'm going to pause when I get to the area of interest. Okay, these images here, I'm just going to scroll back and forth slowly, is where the cause of the melena is. Anyone see anything?
Is there something in the duodenum, third portion?
Yeah, good. So maybe
a foreign
even
body, maybe
third, fourth. So yeah, something you're saying
like
around here.
Linear hyperdensity. Would that be a foreign body?
Yeah, good. Excellent. And so if you're wondering about it, you see this like pointed thing. It looks like it's going in a linear fashion. The coronal is good. And so my colleague Amir picked this up and I thought it was a great pickup because you could have easily completely missed it. And he said he almost missed it, but then like at the last minute, he was looking at the scan and saw the coronal. And so what do you think it is?
Fishbone.
Fishbone.
Yeah, good. So I was just reading a little bit about fish bones. Sometimes they could be chicken bones. We can't really tell, our pathologists can't tell. But some interesting things that I learned was that actually most fish bones get caught in the cervical esophagus, because you can imagine that, that's the first entryway. And the esophagus is actually much more vulnerable to perforation because it's a thinner muscle and it doesn't have an adventitia. So probably our head and neck colleagues are seeing even more cases of these. I've seen a couple going into like the vestibula, but you can even get them perforating out, causing an abscess and going all the way to the skin. The ones I've seen in the abdomen, you know, either they're incidental or they've caused some major havoc. So I saw one that went, you know, from the duodenum towards the SMV and basically caused a thrombophlebitis of the SMV, and then occasionally it can perforate. And then the two spots that it's most likely to perforate is points where the bowel is either taking an angulation or it is tacked down. So the two spots are the ileocecal junction and the rectosigmoid junction, because that's like a curve. So those are the two where the fishbone gets cut up. So in this patient, they actually had melena and they thought that the cause was this fishbone. So they went in with EGD and they could not get down this far because we can see that it's kind of like basically in the jejunum. So they couldn't get this far. Then they went with a small bowel enteroscopy and they still couldn't get the fishbone. And actually we did another scan 2 days later. And so you can see that where the fishbone was before, it is not there, but it has progressed further here. So now it's in the mid-jejunum. Even though they did a small bowel push enteroscopy, they could not find the fishbone. So they're basically just, and then the patient, you know, was doing okay. The melena had stopped. And so they're sent them home. Most of these fishbones will pass. So you don't necessarily need to go and laparoscopically go and remove it. But yeah, it can cause a lot of issues. Okay. My next case is this one. So this is a very T2 hyperintense large mass in the adrenal fossa. And you can see it's actually going into the IVC here, T2 bright mass going all the way up to the heart. So I can show you some more images. Here it is. You can see that bright tumor going up into the right atrium there. So what do you guys think this is? Oh, I'm looking, let me pull up the chat. So Ben is saying ACC, good, excellent. So show you a few more sequences. So there's our ACC, pre-contrast. So ACCs can have hemorrhage within them. So looking for hemorrhage here, don't really see it. About 30% can calcify, don't necessarily see calcification here, but I'm going to show you a PET CT as well. On the arterial phase, lots of motion, but has some enhancement. Like HCC, they can enhance and wash out. They also like to have central necrosis. So this is a very good look with this central necrosis for an ACC. So my question to the group is, do you think, and then we've got a lot of delayed enhancement and then enhancement in the IVC thrombus. So the question is, there is a nodule right here, and there's also kind of this appearance of the omentum here. So what do you guys think? Do you think this is peritoneal disease? How hard would you come down on it?
It kind of looks concerning for peritoneal disease, those nodules that you showed anteriorly.
Yeah, exactly. So I find it sometimes tricky because like it can be very vascular, you know, the omentum, or but we raise the possibility for peritoneal disease here, and then because of that nodule also behind the liver over here. And they ended up getting a PET. So a couple of things to note on the PET. First of all, they did not have a calcification in the lesion, so that did not help us for ACC. But on the, this was the PET CT. I will cut that out later. And you can see that the patient had these patchy FDG avid opacities that were compatible with COVID. The adrenal cortical carcinoma was also fairly avid, which is typical, except for this area of central necrosis. And the omental stuff was not very avid, or was not avid at all. And then there was this kind of homogeneous avidity of the peritoneal fluid, which our nuclear medicine colleague said basically is like a 50-50 chance of being malignant ascites. So they also kind of hedged on it and said it was about 50-50. So, the surgeon kept asking us, like, do you think this is peritoneal disease? Even that little nodule behind the liver was not very avid. But we said based on the MR, we still thought it was. And I'm going to show you. So anyway, this one ended up being adrenal cortical carcinoma, and all of that stuff was peritoneal disease. And just try to, having so many issues. Okay, so this was actually the intraoperative images. And so you can see there's actually lots of nodules here. So tons of nodules. And then this whole omentum, although this all looks like omental fat, it was all like studded with peritoneal disease. So there was extensive peritoneal disease here. So just a couple of notes about adrenal cortical carcinoma. It's pretty rare. There's less than 200,000 cases in the US, whereas adrenal adenomas are seen in 5 to 10% of patients. There is a higher incidence in children because there is a genetic basis for some adrenal cortical carcinoma. So some diseases like Lee-Fraumeni disease, and then also in Brazil, they tend to have more genetic mutations. And so there's a higher incidence. This is really interesting. About 50% will present with hormone excess. So the top one is cortisol. And so you'll get Cushing's disease. You'll present with diabetes and osteoporosis. And this patient actually was really osteoporotic. And another, they said 40 to 50% will also have androgen production. So a female that might be exhibiting male pattern baldness, hirsutism, et cetera. And on imaging, as I mentioned, they're large. They tend to be necrotic, hemorrhagic, 30% with calcification, which I think is a really good clue away from pheochromocytoma, and up to 10% are bilateral, which kind of again goes for the genetic basis. One really interesting thing is that they can have microscopic fat. So if you see a big, heterogeneous, ugly mass, but it happens to have microscopic fat, do not fall down the pathway of, well, this could be an adenoma, because these ACCs can have microscopic fat. And they're much more heterogeneous than an adenoma. They have a fibrous capsule, so they're not infiltrative tumors, unlike, for example, pancreatic adenos, but they can penetrate through their capsule. They can invade the liver or adjacent organs. They love invading the adrenal vein and IVC. We see that all the time. And then through the capsule, they met to the lung, liver, and bones. And usually when they recur, it can be local or peritoneal, which has the worst prognosis. So this particular case had de novo mets to the peritoneum, which is less likely. It's more likely that you get that when they recur, but has a very poor prognosis.
I remember reading about peritoneal carcinomatosis, not in the setting of ACC, adrenal cortical carcinoma, but in the setting of gastric cancer. And like my surgeon, and like it says like our ability to detect peritoneal carcinomas is actually very low. Like, I mean, it's 50% of the patients will have carcinomatosis, and it won't be obvious on imaging. So I mean, in this case, it's obvious. So that means that your PPV is going to be even higher, right? I mean, if it's just something that we don't see very well, especially if it's,
Yeah, and there are papers out there showing that like diffusion weighted imaging on MR can help you, but I don't find it actually that helpful. So I find it to be problematic. But definitely gastric cancer, like it's such a high prevalence that they'll do a laparoscopic staging laparoscopy just to, because it's such a high prevalence of having peritoneal carcinomatosis. My urologist was saying, he doesn't usually see this in ACC, so this was like a really aggressive one. One final point about peritoneal carcinomatosis. So there's multiple ways that you can get carcinomatosis to your peritoneum. The one is just hematogenous. The tumor makes the capillaries leaky of the omentum. So as the tumor cells are circulating in the blood of the omentum, they're not only circulating, but the capillaries are leaky, and then it basically seeds into the omentum. You can get contiguous from an organ. So we see that a lot with gastric cancer going into the omentum. We don't necessarily consider that peritoneal carcinomatosis, but just adjacent involvement. It can be from lymphatic spread. So it's going through the lymph system and getting into the omentum that has a lot of lymphatics. And then I think this is really interesting. So it can gravity, say you get some cells in your abdomen, these are the places you're going to see the tumor like nodules falling to because of gravity. So the pouch of Douglas in the pelvis, the sigmoid mesocolon, the ileocecal junction, like around the appendix and terminal ileum, and the right pericollic gutter. And that's just because of gravity. And then when you have your peritoneal flow, it'll actually push it onto the top of the liver. So between the right liver and the diaphragm is a great place. So always look on your coronal and into the left pericolic gutter. And then one final thing is that if you have ascites, even if you have ascites, it could be malignant ascites, like actually cells in the peritoneum that are producing ascites, and you can possibly get cells in the ascites if you tap it, but it's often actually just from obstruction of the lymphatics. So these subphrenic lymphatics between the liver and the diaphragm, they become blocked with tumor cells, and that means that it doesn't allow the ascites to be resorbed, and that's why you get ascites in these patients. So the ascites itself, when you tap it, might not have cells in it because it's just from obstruction. And you can also get ascites from that increased capillary permeability, like albumin and protein. Okay, those are my only slides for today. My soliloquy is over. Let me pause my share here, and I just have one more case.
And then when you finish, I can share mine. I brought up 3 cases. I don't have any slides, but we'll just discuss it as a group.
Awesome. And Victoria says she has cases too. So, okay, this is the last one. So liver, what do people think?
There's like a shunt or something.
Some weird vasculature there.
Yeah, so there's several comma-shaped shunts. So here's a comma-shaped shunt. That the comma-shaped is like a, I don't know, something they talk about in the literature. So there's multiple shunts, and they seem to be going between the portal vein and the accessory right hepatic vein, as well as into this right hepatic vein. And then we don't see the middle or left hepatic veins well. And our IVC is very, very diminutive.
This is Bud Chiari then.
Yeah, so this was a case of Bud Chiari with intrahepatic collaterals. So I just thought this was a really pretty case of these intrahepatic collateral vessels. And it's almost like an auto TIPS. So, you know, these patients, their liver becomes so congested. One of the treatments for Bud Chiari is doing a TIPS procedure to kind of decongest the liver. But the liver will also rapidly make these shunts. So you're kind of like auto TIPSing yourself so that the blood flow can leave. I'll just show you one more sequence where here we thought also that there was a little bit of thrombus in that IVC and the upper IVC before it kind of basically disappears. I'll show you on the, and you can see that also that there's a big azygos here and lots of lumbar veins because that very tiny IVC needs to shunt through all these lumbar veins, including this huge shunt here between the left renal vein and the lumbar vein into the azygos. Okay, that's it for me. Nelly, do you want to go?
I have 3 cases, and I don't have any slides prepared because I just brought it up spontaneously. So I'm hoping people will just pitch in their experience and thoughts about teaching points relevant to these cases. The first one is, so this is a patient with a history of like recurrent UTIs, and on imaging, there's all these like cystic spaces within the wall of the bladder. The patient had positive UA, and had like clinically had evidence of recurrent UTI. So to me, I thought this was cystitis, cystica. And I looked it up on Google, and just a couple the teaching points, I guess, is it happens in patients with recurrent UTI, and it's sort of like a chronic condition. And the response that the bladder has to recurrent sort of inflammation and infection. Any thoughts from Aarti or Steve or anyone else?
Yeah, this is Steve. I think of this more as a urothelial phenomenon.
Yeah.
Your case you're showing looks so mural. that I don't know, maybe it's just because the bladder's collapsed and it's a fake out that it's like really, if you had a distended bladder, it would be on the inside of the wall.
Yeah, Nelly, what's up with their rectum and sigmoid colon? It looks so featureless and like distended. Have they had
Thought
treatment
that
for
was the
anything, or
bladder.
do they have like ulcerative colitis?
I'm going to pause my share so that I can pull up the report. I don't, just one second. So keep talking while I pull up pause share.
Because a mural issue that could look like cystitis cystica in a collapsed bladder where you really couldn't tell what you're looking at might be some diverticula within the bladder wall that are trapping some fluid too.
No, that's true.
I think they also bought themselves like a cystoscopy because I'm not sure
Right.
it could be malignant.
The patient does have a history of C. diff and it's recovering. So that may explain some of the colonic findings that we're seeing.
I do remember that cystitis cystica is, as you said, chronic inflammation leads to it. More common in females. Basically, cystitis is more common in females. And you can get ureteritis cystica as well. It's basically the same idea, only ureteral involvement with chronic inflammation.
Awesome. Okay.
Nelly,
so,
just out of curiosity, I just
yes.
Googled it and you
Yeah.
can get C. diff of the bladder, but I don't know.
Wow. That's a great question. I mean, the patient was septic. I think the patient was being treated for C. diff. So I'm not sure if the cultures were at the time. That's crazy. Next case. This is a patient who came in. What do you guys think?
So Nelly, what
Yes,
was that case
yes.
in the end?
This was a recent case. So
Oh, got it.
yeah. Okay. So anything from anyone?
Inflammation around the proximal bowel, small bowel.
Yeah, right here. And then on the coronal, someone is texting in and I can't see the text. So hopefully somebody will just talk. And it's right here. What do you think?
Ectopic pancreas.
God, brilliant. So this is,
is it true?
that's what it was. Yeah. This was,
Oh, what a gunslinger, Aarti.
I don't know that I would could boldly just give that as the only DDX, to be honest with you. I mean, would you have? How would you have?
So Nelly, this is Kumar. Oh, go ahead.
Oh, no, go ahead, Kumar.
So we had a paper published just exactly like this.
Really?
Yeah, and I mean, just would come in the differential, but with all the inflammation around it, I think ectopic pancreas with pancreatitis is your number one. The only thing that might help is if you can see a duct within that, and if you zoom it up, sometimes you see a duct, like in its pancreas, so it'll have a duct. You may not. I don't know if you can fool yourself into thinking there's a duct in there. Maybe not. But anyway, I would have put, with all the inflammation around it, I would have put pancreatitis as heterotopic pancreatitis.
I didn't appreciate the mass at first, but I guess once you appreciate that there's like a mass there that's along the bowel wall, then you have to come up with a reason why you're getting a mass with that much inflammation.
Mm-hmm. Yeah, so something to think about when you see a proximal bowel mass with inflammation is ectopic pancreatitis, which is what this was.
Yeah, Nelly, I have a case.
Yeah.
I think it actually ended up in Kumar's paper because I gave it to Cookie and then it ended up in that paper. But it's like it was an entirely second formed pancreas from that exact location, and you could see the duct. So that was cool.
That's awesome.
But I remember looking up at the time that the most common location for ectopic pancreas is going to be the antrum distal stomach.
Mm-hmm.
And so that is much harder to diagnose, except if you have a lot of inflammation there, that ectopic pancreas is there, and then also you can get it in a Meckel's, but basically you can get it anywhere along the GI tract. So if you see a fluffy thing with inflammation around it, think about ectopic.
Awesome. And then this is my third case. This is a patient with history of hysterectomy for leiomyomatosis. This is a post-operative CT The patient at the time of surgery had vascular invasion and had recurrence, which was then resected. And so this is a recurrence after the resection of the initial recurrence. And I'm showing this case because I mean, it's just a really phenomenal case of recurrent leiomyomatosis. And in this case here, we have the recurrence here, and then the mass grows into the collateral vessels. The patient had right common iliac vein was resected during the initial resection of the recurrence because there was intravascular invasion. So we have tons of collaterals, and there's, the mass is growing into these collaterals. So it's just really...
I've seen case reports where they show intravascular invasion of leiomyomas, but it was never this beautiful.
Yeah, it's just a phenomenal, great leiomyomatosis, and it's path proven.
Nelly, one point I would make about those cases is
Yeah,
that on the T2s, you saw those flavoids, and here you can see these flavoids, right?
Yes,
so it would lean much more towards a leiomyoma than like a leiomyosarcoma, for example, which can also invade the veins. So like when we're on the border, it's invading a vein, I kind of give both as a differential, like an invasive leiomyomatosis versus a leiomyosarcoma. The more evil gray, ill-defined borders and more going to go towards leiomyosarcoma. This one is like pretty well-defined, beautiful flavoid. So I don't know. I think we could lean towards invasive leiomyoma.
I mean, they have pathology which supports a non-sarcomatous
yeah, I just mean if we saw this like de novo.
Oh, gotcha, understood. Okay, awesome. So those are my 3 cases.
So Nelly, I do have another comment on this case. So there's another entity, and I'm not sure if it's the same as what you're showing, where when leiomyomas get morselized, which used to happen a lot 10 years ago, afterwards they can be seeded, probably like how a pseudomyxoma is mechanically seeded all throughout the peritoneum, and you can see numerous masses throughout the abdominal cavity. And that Matt Heller wrote a paper on that, and I think he called it wandering leiomyomatosis or something like that. So multiple solid enhancing masses after treatment of a leiomyoma, not necessarily hysterectomy, just morselization, it can happen. And that's why I think we're going away from doing morselization. I think there was also a lot of litigation about that as well. So, so it doesn't necessarily have to be due to vascular invasion.
I see.
And there's the true benign leiomyomas that actually metastasize. That's a ridiculous oxymoron where you get benign metastasizing leiomyomatosis with pulmonary nodules that are pretty indolent.
Yeah, actually, so Kumar, related to what you just said, there's 3 entities. One is disseminated leiomyomatosis, which can happen after morselization. One is metastasizing leiomyoma, which you don't have a prior history of surgery, but you get like a fibroid in your lung or like other places. And it's not clear it's actually metastasizing versus, just popping up in these places.
For lack of a better term, I guess.
Yeah. And then the third one, they call either invasive or intravenous leiomyoma, where you can just have a fibroid that grows up. And you can even have it grow all the way up the IVC into the heart. And it's a benign thing. It just happened to go into the vessel. In those cases, they can just peel open the IVC, peel out the fibroid, and then close up the IVC. So yeah, very different. And then morselization is definitely out because there were several high profile cases where they disseminated leiomyosarcomas that were hiding in a sea of fibroids. And so they've basically it's not used anymore. Okay, Katie, you want to go?
Yes, I would love to. Hi, everybody. It's Katie Gardner from University of New Mexico. Let me find out how I share here.
You sure and hide the PHI.
Yes, I've got it off. Okay. Okay, here we go. So this is a young female and our gyn-onc friends gave us a call wanting us to tell them, where is this coming from? This mass here in the right ischiorectal fossa. And what is this thing? It's pushing up through the pelvic floor. There's mass effect on the vagina and the rectum. Pretty smoothly marginated. It was enhancing. This was an enhanced CT. look at the way it is pushing up on the pelvic floor into the pelvis. How bizarre. So, and if you look close, you can see you want to think that it's homogeneous, but there are areas of increased attenuation within it here. I see we're getting something in the chat. Let me just peek here. Oh yeah, anybody have a guess? Just on the CT.
A solitary fibrous tumor.
Yeah, that's a good guess. What else?
We've shown this case before here.
Really?
Yeah. But I don't expect you to remember all the cases. But usually we bring up aggressive angiomyxoma.
Yes. Yes, so that's what we led with for our differential on this. We also considered cellular angiofibroma, myxoid mesenchymal neoplasm. Let me show you the MRI. So, about a 14 centimeter mass here with this world sort of appearance, even before contrast. So, any other thoughts at all?
It's interesting because aggressive angiomyxoma is usually much more T2 bright. And this one almost looks similar to that fibroid.
Mm-hmm.
Is it connected
does.
to this at all? Or
Yeah,
I wonder if it's like
exactly
You're on something.
Great job. Yeah. So the path came back with a low grade smooth muscle neoplasm, and they said an extrauterine leiomyoma.
Wow.
Crazy.
Mm-hmm.
Is it connected at all to anything? Like, no, it's not.
So it's really difficult to find what it's hard. They had to take out some of the pelvic floor musculature along with it. There was just too much involvement here on this right side. They ended up taking some of the muscle with it, but not really. I mean, I don't know that we ever decided exactly what is the origin here. We just kind of said it's central. The central part of it is in the right ischiorectal fossa.
And we have seen over the years and case reports and stuff like that, leiomyomas at any sort of place, even as a solitary thing, usually around the female pelvis. And then as you get further away from the pelvis, fewer of them. She happens to have some additional fibroids in the uterus, maybe with similar appearance even, but I think when I've read about this, that there's something about the hormonal milieu of a female pelvis that's able to initiate and or support leiomyomas forming in and around the uterus and adnexa. But I've not seen one below the pelvic floor before.
Yeah, this is a great case. And one thing is that it's probably a much better prognosis than the aggressive mixed angiomyxoma because those have like a lot of local recurrence.
Mm-hmm. Yeah, she's lucky.
As lucky as you can be with a 14
as long as they
mass.
Right.
Yeah, it's always tricky also to like preserve those pelvic muscles when they're doing the surgery.
Yeah, hopefully she doesn't have too much weakness because we know that can lead to all sorts of things.
Awesome. Victoria?
A companion case.
Hey, can you hear me?
Mm-hmm.
Okay, sorry. I have several very quick questions. Quick cases.
Cool. While you're pulling them up, Victoria, I had a question for you from one of my colleagues.
Oh.
Was if you have it's a LIRADS question, of course. If you have a nice arterial phase on a recent exam and it shows AFI, and then but you don't have like a good delayed phase, and then you have the next exam, the arterial phase is all motiony. Can you add together those exams kind of provisionally and say, we think this still has AFI?
Right. So it's a fantastic question. With caution, yes. We tried when we're taking it, releasing version 2018, we try to create some sort of guidance on, the temporal, the temporal time, the time difference between the two exams that you can use. there's just no good data that shows, we were thinking about within 3 months is okay, but that's just purely, based on what we think is okay. So the answer is there's no data on it, but provisionally you can do that and say, arterial phase hyperenhancement was demonstrated on X study. And
Okay, and do you know if it makes a difference for transplant? Like they won't allow that kind of report for transplant?
They generally, you may, the chances are patient is going to get many follow-ups, or at least I don't know like how fast you guys get transplant. Our patients sit on transplant for years, so they're going to get follow-up anyway. But let's say that was the study that needs to be qualified. It may need to be placed as a narrative and explain what happened, but I think it's reasonable.
Okay, thank you.
Okay, so this is a case, and I'm just in keeping with a pancreas theme, I guess, not intentionally, but this is a fairly old case from 2013, so I can't tell you what the symptoms were or why, but here's the finding. Any thoughts?
Kind of like a malformed pancreas, like it's not fused properly.
Right. So that's one thing, right? So this bud, it doesn't seem to be fused with this one.
It's confusing because the part that ends up ventral is called the dorsal pancreas because of the rotation. But that piece that you just showed is technically called the dorsal, right?
I think you're right. I always get confused.
Yeah, that's the dorsal one.
Right.
You can see that this dorsal bud is okay, but in the ventral bud, you can see that there's an enhancing mass, which kind of follows.
Yeah, I'm thinking like an infiltrative neuroendocrine.
Yeah, so that was exactly what it was. This is an infiltrative neuroendocrine, and it's only in the dorsal bud. In the ventral bud is fine. You can see how it's much more difficult to pick it up on the.
Tough to see on the venous phase.
Right. So so that's like one of the examples why it's good, for pancreatic cortical, we need both arterial and portal venous phase. You can see how nicely this.
Is that a little bit of dilated duct?
Yeah, right here. Well, patient had cholecystectomy. I'm not sure this is due to obstruction or maybe a combination of obstruction.
Victoria, it's a little hard to hear you.
Oh God, I already bought a new microphone and everything.
No, now it's much better.
Now it's great.
Yeah, just hold it
A
close.
lot of these microphones require your mouth to be really close to it. Otherwise, you're not picking up anything.
Okay. Is this better?
Yes.
Much better.
I'm like literally on top of it.
That's where you gotta be. You gotta be like a rock.
Anyway, so this was just a cute case of malformation and this very unusual appearance of the neuroendocrine tumor.
Yeah, Victoria, I like that case because people often think like neuroendocrine has to be like a small ball, like a rounded, enhancing thing, but sometimes it really just infiltrates and takes over the whole pancreas.
Right. So this is another case. Forgive the quality for it is, it is very old case, but
is there a gallbladder duplication?
Yeah. So this is a case of gallbladder duplication, and unfortunately, this is an MR. This is old MR. You can see two gallbladders sitting right on top of each other, and this is a companion case. And you can see the same thing on the axial, where you see just gallbladder. But look at the sagittal. You can actually see very, very nicely the two gallbladders sitting right next to each other. See that? So it's just 1 and 2.
Wow.
Somewhere I have a case of one of those we picked up on a HIDA.
Yeah. So
on the axial, Victoria, I was going to say that hourglass gallbladder, like adenomyomatosis, but that sagittal is beautiful.
Right. So on the MR, it's harder because you kind of have you have to in your mind kind of figure it out, because I think the sagittal is sagittal is super easy. On coronal, you sort of kind of see it, but you sort of have to reconstruct this from axial and coronal. But I think the sagittal here is just so like right there in your face.
Is there also a really low insertion of the cystic duct? Kind of looked like that in your MRI.
Yeah. Do they each have their own cystic duct?
Here, let's see. Here it looks like they're joining together right there. On the MRI, that I think there was a low insertion there. This is the here we go. This is a cystic duct coming down and inserting very low inferiorly at the level of like right before the ampulla. Okay, and then the next case is, it was an ER case. Patient had an abdominal pain, and here's kind of an incidental finding of this lesion, and here it is on a coronal. And then here's the reconstructions with a convenient arrow pointing to it. Don't you love when patients comes with errors? Anyway, so what do you know? Anybody has any thoughts about like what the differential is? And...
For me, it's a differential.
Okay.
I don't see gross fat. Do I?
No, there were no gross fat.
Arwa is saying clear cell.
Right. So we're thinking about, either clear cell or some sort of cystic, cystic and solid mass. There's one thing here that kind of give, once I tell you the diagnosis, you're like, oh, cool. I don't know why it's jumping like this, but.
I feel like you want us to see that it might be herniating into the renal pelvis, but otherwise it doesn't really look like a multilocular cystic nephroma to me. It looks too solid.
Solid, right?
But this is what it was. This was multilocular cystic nephroma.
Somebody like sucked all the fluid out.
Well, all these thingies, right, are a little little cystic spaces. And obviously this is not something that can be called prospectively, prospectively.
Yeah, a lot of these are surgical anyway.
Right. So we just called it like a complex cystic and solid mass. I don't know why it's jumping. I apologize.
Bosniak, took it out.
Right. So this would be Bosniak 4, but in retrospect, you can see it does herniate into one of the calyces. So it does do the, and this was a middle-aged woman, so that works, right? In terms of the demographics for this patient.
What if you could get a papillary urothelial cancer looking something like that too?
Right. I mean, again, this is not something that can be prospectively, or even if you thought about it, like you still need surgery. But okay, the final case is just very quick. Patient has a hernia on the left, and this is just something. Obviously we see hernias a lot, but I've never seen a hernia where you can see this is the ovary, and this is part of the fallopian tube just going into the hernia.
Oh yeah.
So it was just I've never seen a fallopian tube going into hernia, but here it is.
The hernia that ate my adnexa.
Yeah.
Victoria, can you go through the axial one more time?
You can see here's the uterus, right? And so as you go down, this is the ovary, and as you're coming down, you see something that comes down into the hernia sac.
The only thing that's bothering me is that fat next to it. Like it almost looks a little dirty and like it's like a little mass-like.
It was just hernia, but it may be a little what do you call it?
Inflamed or something.
Inflamed or a strangulation of the fat. But that's what it was. She ended up having surgery, and it was just I've never actually seen adnexa. We've seen I've seen bladder protruding, obviously bowel, but I think this is the only time I've seen some adnexal stuff protruding into
A lot of rotten eponyms with these.
There's eponym for this?
No, I don't know. Not this one.
I think there is actually. There's on the line. There's this list of hernia eponyms.
Things you find in your hernia. Fill in the blank eponym.
Right. So those are the cases I had. I didn't have any liver cases today. I decided to take a little break from liver.
Very cool. And for the group, the reason I was bringing up the dirty fat was just sometimes these are liposarcomas that are masquerading as a fat-containing inguinal hernia. So anytime you see an inguinal hernia that has more mass effect or stranding or kind of complexity to it, especially in a male. Think about a liposarcoma going into the scrotal sac. Okay, does anyone else have cases?
Hi, this is Kumar. I have one case I can show. It's on a PowerPoint, so it should not have any PHI. Is that
Yeah.
okay?
Yeah, that'd be great.
All right, I'm going to share screen 6. Okay. I've shown this case already to the others. Can you see my screen?
Yes.
Oh, good. It says case 2. You can see that, right? So it's in a boards type question. And so I think our fellows have seen it. So I don't particularly want Teresa to take it, but anybody else wants to take, any other fellow online can take it. So it's, why did I say it's actually a 24-year-old female who has male who had a mixed germ cell tumor from the testis, and it's a mixed with various components. And we have 2 images, one early on and one 8 months later. So I'd like somebody to talk through it and give me what's the right answer.
I mean, when I see this, what comes to my mind is growing teratoma syndrome. And if that is the case, then I mean, those are resistant to chemotherapy and they have to be surgically managed.
Very good. Excellent. So the points to make are there is this tumor that has suddenly grown. However, all the malignant markers, which is the AFP and the LDH, are all down. So why is the tumor growing when chemo, apparently it's looking better on the malignant side from the lab test. So yep, that's the correct answer. And if my mouse will let me move, well, okay, so it is growing teratoma syndrome. And what basically happens is you have a mixed germ cell tumor, and with chemotherapy, you kill off most of the malignant cells. However, a clone of them will differentiate into a mature teratoma, which is no longer sensitive to the chemo, and that'll keep growing. And the only way to remove that is surgical. And you might see changes just like in a dermoid cyst with calcium and hair and all of that. And that's what happened here. So sometimes getting bigger doesn't necessarily doesn't mean it's getting more malignant. It's just a different clone of that is no longer responding to what you're giving. And that's actually Cookie wrote a paper on this. So if you Google Cookie's research radiographics papers, you can come up with all.
In half an hour, you might find this one among the rest of them.
Yeah, I just have one case. I actually do have more cases on this PowerPoint, but I don't want to present all of them at once.
Kumar, I have a question for you. When you say it differentiates into a mature teratoma, we often think of mature teratomas or dermoids as benign lesions. Would you say, like, now that it's, I mean, it seems like it's growing really rapidly, so that would suggest to me that it's not really benign, but like, why is a mature teratoma growing so quickly?
That's a good question. I think teratomas can grow and it could be multiple clones started growing and each one grew, into a different part. I don't know for sure, but the histology was mature teratoma when this was taken out. So as to how it could have grown so quickly, I wonder if it's different from a de novo mature teratoma, which usually don't grow they do grow, but not very much. And whether this, even though histologically is the same, has a different biology. I don't know for sure about that. That's a good question to look into.
Yeah, that makes sense to me. Like maybe it's a different kind of biology than the de novo.
Yeah.
Okay, thank you.
All right, that's my case, so.
Okay, anyone else?
I'll stop sharing if I can.
I have a case to share, but it's not like super awesome. It's just something that I kind of want the fellows to see, if that's okay.
Yeah, that'd be great.
All right, I might need Teresa's help to share this anonymously. Let's see here. Advanced. I don't want to say too much about it and get dinged for saying the wrong things, but and I just want to kind of go through it, just my thought process. So This is a young patient with an obvious liver lesion here, T2 right, and the top two sequences are both T2. Does anyone see any other liver lesions on this T2?
I don't.
Okay.
No.
Okay, and that's pretty much what happened to me as well. So I guess the next sequence I can go over is well, I'll go over the arterial in a moment, but this is a 5-minute delay, and that T2 lesion enhances, so you can see that. But what I didn't see is there's another lesion right there. And so I did miss that. Now the arterial just makes all of this very obvious, so there's little enhancing foci everywhere, different sizes. There's probably some enhancement associated with that tiny one there. And there's some bigger ones coming up here as well.
They're probably all hemangiomas, and yet go back to the T2, you start seeing them.
I'm thinking maybe neuroendocrine mets.
Oh, and maybe they're Mets, huh?
And maybe diffusion would help.
Diffusion would help.
Okay, good. Yeah, so those are both
combination.
Both good thoughts. I guess what struck me is that, I mean, you just really don't see a lot of other lesions except for just this one really on either of the T2 sequences. So let me just show you the diffusion sequence here. Let me pull one up here. Oh, sorry.
And I just heard Gitanjali also saying a combination of FNH and hemangioma. And I think she's saying the FNH because we only see these larger lesions on the arterial. And that's a great thought.
Yeah. So one of these does have restricted diffusion. Does that change anything? And there could be more than one kind of lesion here, really, but
it does change for me because neuroendocrine, usually they light up on the diffusion. So I'm less thinking that.
Okay. So maybe question mark combination of FNH and hemangiomas, still some neuroendocrine mets, but maybe less likely because, relative to how many arterially enhancing lesions there are. I really only think there's probably this one is the one that has the most striking restricted diffusion. So let me just show you the like a follow-up study. And again, I want to just shrink this box and make sure I do this correctly here.
That's good.
Okay, good, perfect.
Pat?
Well, I'll just show you and then maybe we can talk about it. So basically, this is a dotatate PET, which pretty much gives it away. But this patient is a young female with a history of perigangliomas, carotid bodies. So I just wanted to show mostly the fellows as
Periganglioma mets then?
I mean, this is a recent case. I think that's probably what is going on here. But I just wanted to show, like I said, mostly the trainees. Yes, there are some. But it was just interesting to me that something could be so subtle on T. Like I really only saw one lesion, and I don't even think that lesion in particular is one of them. So, because you can see there's that one doesn't light up. So, I mean, basically those lesions were they were like hiding on the T2. I pretty much didn't see any of them.
Yeah, I'm really surprised they were hiding on the diffusion too. But this is the tricky thing about neuroendocrine, which is what a lot of people advocate, that dotatate is really, really the test to go, especially these bone mets. You'll see a lot more of them on dotatate than on MR or CT. And PET MR can be a nice future combo study that will, help you see which ones are mets and then quantify or like diagnose the other liver lesions.
Yeah.
Some of the smallest little enhancing foci you just never saw again on the arterial phase. like not even the dodatate's positive in those sites necessarily, but maybe it's just more of the same.
Yeah, I think if they're too small, and they don't have enough of that somatostatin 2 receptor, they won't light up. But yeah, you can see how much like beautifully they light up here. So it's like dodatate's definitely the way to go.
Yeah, I just wanted to share that because I just wanted everyone, all the trainees, to see that sometimes these lesions just really aren't that well seen on your regular sequences, like
Yep.
the T2.
Does anyone know if, I think that I remember my nuclear medicine colleagues telling me that dotatate is also pretty good for paragangliomas, and better than MIBG, but especially for paragangliomas of the neck, not as proven in the abdomen. But I think if this is metastatic paraganglioma, this is a nice case of like dotatate would be good for that, and maybe even better than MIBG. Anyone know?
I think I've read that that's true, but you know, don't quote me on it.
I'm quoting you on it. Great case. Thank you so much, Regino.
Thank you.
Okay, it's 3 o'clock. I'll see you guys later. Bye.
Bye.
Bye.